Hello, everyone, and welcome to the January 2023 Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estebillo, Director of Training for the Tarjan Center, and it's my pleasure to be here with you today. Before we get started, a few reminders. We offer live Spanish interpretation, and you can click on the interpretation button on the bottom of your Zoom toolbar and select Spanish for interpretation. I'll hand things off to our interpreter, Sol Garza, to go over instructions now.
Hola y bienvenido a la reunión de hoy. Si desea escuchar el programa interpretado al español, favor de oprimir el icono de globo que aparecerá en la pantalla de su dispositivo o en la sección de aplicaciones. Escoja español. Para escuchar el programa interpretado solo al español, favor de oprimir silenciar audio original. Disfrute de la reunión. The interpreter is ready for interpretation to be enabled.
Thank you, Sol. Okay, please also enter your questions for our speaker into the Q&A function throughout the talk, and we'll facilitate discussion at the end of the presentation. After today's lecture, please be sure to complete our evaluation survey. We love to hear from our audience on what topics they're interested in and how we can better serve the needs of the Tarjan community. And with that, I'll introduce our speaker. Dr. Kelly Vitzthum serves as the Associate Director of the Community-Based Clinical Education and is the Health Sciences Clinical Instructor at the UCLA School of Dentistry in the sections of Public and Population Health and Special Patient Care. She has various work and research experiences in special care dentistry, consumer health advocacy, health literacy, and quality improvement in the healthcare safety net. She received her MPH from the Harvard T.H. Chan School of Public Health and DDS from the UCLA School of Dentistry, and she completed a general practice residency at UCLA. Please join me in welcoming our speaker, Dr. Kelly Vitzthum.
Hi, everyone. Thank you so much, Dr. Estebillo, for that introduction. Let me go ahead and share my screen. Okay. So for today's presentation, I'll be discussing dental services for individuals with disabilities with a closer look at dental education, policy, and care delivery. I want to recognize that I will inevitably leave out a lot in this conversation. And for the purpose of this talk, I'll be focusing just on the adult population and not just on those with intellectual and developmental disabilities, but really anyone who has trouble seeing the dentist because of any type of special healthcare need. And at least in the dental world, we tend to use the term special care dentistry to describe these dental services that are specifically tailored to seeing these patients. I have no conflicts of interest. And here are some learning objectives for today. So to describe the existing challenges in obtaining dental care for people with special healthcare needs, understand how changes in dental education and training can improve access to special care dentistry, identify the various policy facilitators and barriers to improved care delivery and financing for people with special healthcare needs. I'd like to emphasize just how common disabilities are. So according to the CDC, 61 million adults have at least one disability. That's over a quarter of all American adults. And if you look at the types of functional disabilities, the most common are mobility-related disabilities at 13.7%, followed by cognitive disabilities, and then difficulties with independent living. A not insignificant percentage of people also have trouble with self-care. And I just want you to see why all of these are important and how all of them directly impact the ability to maintain one's own oral health. So people with disabilities tend to have more health challenges, and this is a bidirectional relationship, disability and serious illness. People with disabilities are much more likely to experience a serious illness, and those with serious illnesses are more likely to have a disability as well. This is, of course, also very true for those who have specifically intellectual or developmental disabilities. There's a lot of overlap with medical complexities. And I know I said earlier that this lecture is about adults, but we must also remember that children with disabilities become adults. And as chronic diseases common to adulthood crop up, it only increases the complexity of care that's required. This is also especially true when discussing aging and the unique health needs of older adults. And one thing to recognize is that the process itself of aging is not just biological, but also involves psychological and social processes. Many of these life transitions from childhood to adolescence to adulthood, to older adulthood, they also represent transitions in both healthcare as well as living arrangements. So some challenges while at the dentist for an individual with disabilities, right? Depending on the disability, you might have behavioral challenges. So that's understanding directions, being able to do at-home oral hygiene and self-care, being able to adhere to medication regimens. It's confusing for all of us. And of course, just general fear and anxiety. Again, something that's not really just unique to folks with disabilities. You also have mobility challenges. So transferring to a dental chair, for example, movement problems. A lot of movement disorders are characterized by uncontrolled body movements, which can make routine dental care kind of scary. Think higher aspiration risk, swallowing issues, gagging, and of course, patient and operator safety, especially around sharp instruments and rotary handpieces that go at 200,000 RPMs. And more of a catch-all too, just medical complexities, right? You're thinking anything from seizures, cardiac issues, respiratory compromise, immunocompromise, cancer treatment, and all of these can complicate care and require a lot of coordination just to ensure that dental care, even basic dental care, can be delivered safely. Oral health problems are also more severe in those with special healthcare needs. Some people may be at higher risk of developing tooth decay, and this might be just due to the higher sugar content seen in many medications. You tend to see this a lot in children's formulations of medications. They add a lot of sugar to them just to make them more palatable. There's also medication-induced xerostomia or dry mouth. So that's a very common side effect of a lot of medications and can definitely predispose you to dental caries. Or just the general inability to tolerate or perform oral health, which can also predispose you to gum disease. Medications, we just talked about, they can also cause excess gingival growth. So you have larger gums that are puffy, swollen. That could be both very uncomfortable as well as unhygienic and difficult to clean. Varied oral anatomy too, and this is quite commonly seen as part of many syndromes. Sometimes it's congenitally missing or extra teeth. You have a high palate form, narrow or small jaws, even malformations of the tooth structure itself. And this can lead to significant challenges with dental treatment. Sometimes the teeth are just very prone to decay or gum problems. And sometimes people's mouths can be so small that it's difficult to see, much less do any dental work on teeth. And in terms of trauma, individuals with poor muscle control, seizures, or even self-injurious behavior may be predisposed to more frequent falls. That can lead to avulsed teeth, just general oral trauma. So that's something to also be aware of. And we talked about earlier, people with disabilities are, again, much more likely to have multiple comorbidities. There's more and more literature also coming out nowadays demonstrating that a lot of systemic diseases actually have oral manifestations. So we're starting to understand that interplay. And just in general, people with special healthcare needs also tend to have infrequent dental visits, especially if they need to be maybe sedated or they need to be seen in the OR for treatment, just for their own safety or, due to medical complexities. And, for dentists, we may need to be more aggressive when treatment planning cases, since we don't have the luxury in these instances of seeing whether something that's borderline will resolve in a few weeks. You're really kind of have to get everything done in one go, unfortunately. So again, dental treatment tends to be more aggressive too, unfortunately. So the 2000 Surgeon General's report, this landmark report discussed several things related to disabilities. People who have them tend to have worse oral health than the overall population. And of course, there are persistent financial, workforce, and logistical barriers to access. And at the time of writing, there had been no national studies conducted to determine the overall prevalence of oral and craniofacial diseases among those with disabilities. And a little over a year ago, the NIH released the much anticipated new report on oral health in America as a follow-up to that 2000 Surgeon General's report. So post-Affordable Care Act, there's still inconsistent coverage of adults with disabilities, and a significant percentage of folks with disabilities are on public insurance. And of course, Medicaid expansion for this population, or just Medicaid expansion in general, is state by state. So unfortunately, not all states have comprehensive dental coverage for this population, and even fewer have comprehensive dental, fewer for adults without disabilities. So nobody's really quantified the problem, even though we all know there is a problem. And unfortunately, because we're not really capturing a lot of this data, it's an invisible problem to policymakers, is the long and short of it. And from 2000 to 2021, so that's 20 years, not much has changed. A lot of the same issues are still present. But I just want to step back for a second and just think, is there anything unique about dental care? So I'll just go ahead and read these quotes. With few exceptions, maintenance of oral health through a lifetime requires timely receipt of advice for self-care, preventive therapies, early detection and treatment of problems, and restoration of function. And almost everyone experiences oral diseases and conditions over a lifetime. And unlike the common cold, most diseases do not resolve over time. And this is, again, from the Surgeon General report from the year 2000. So in a nutshell, maintaining one's own oral health requires active management through the lifespan, both with at-home self-care and, in virtually all cases, regular preventive care with dental providers. So let's be honest, this is hard to do for anyone, not just those with functional limitations, right? So who's had a cavity before? Who's needed their teeth cleaned regularly? Pretty much all of us with teeth would raise our hands there. So it then makes sense that additional barriers to care, say an insufficient workforce, financial obstacles, et cetera, they can easily create significant oral health disparities. And unfortunately, that's what we see. What's unique about dental care? So more on a systems level, dentistry is functionally separate from the rest of the healthcare system. It's very much a historical accident that it's become so separated, but our doctors and practitioners have separate education and training. Physicians have 4 years of medical school, dentists have 4 years of dental school. Medical insurance does not cover dental services. You generally have to buy dental insurance separately. Separate codes even exist for both billing and procedures. And dental practitioners generally don't work in hospitals and medical clinics. They have their own practices that just aren't really integrated with other providers. Even our electronic health record systems don't even talk to each other, generally speaking. So the mouth really has become separated from the rest of the body, which only complicates things when it comes to patient care. The mouth is just another organ system, but one that requires periodic care. And so I would argue, oral health is primary care for everyone, and especially for people with healthcare complexities. The fact that your dentist isn't really a part of your medical team makes coordinating that care just so much harder. So let's look a little bit more in detail at dental care delivery and financing. So for the US population as a whole, most dental spending is either private or out of pocket, and most care is delivered through the private sector. This is in contrast with hospital care and physician and clinical services, where out-of-pocket expenses are minimized and the vast majority of expenditures are via third-party payer, either private insurance or much more significantly through public insurance, that is Medicaid and Medicare. The payer mix also looks different for individuals with disabilities, with public insurance covering a much more significant percentage of spending, especially in states where adult Medicaid benefits were expanded. But for this population, Medicaid is a huge player. 60% approximately of people with disabilities rely on Medicaid. Depending on the study you cite, it might be higher. I've seen 70+%. But again, it's a huge player. And for dental services, although a significant portion of patients with special healthcare needs are seen in the private sector, the most complex patients are kind of shut out from that. And we'll talk about that a little bit more later. And they're oftentimes can only access a separate system of care. And that system, if you can even call it that, is really just a patchwork network of providers, and also through tertiary care centers and dental schools like UCLA. So as we just discussed, if you have any sort of special healthcare need, you can first try to find a private provider in your own community. This way, you can generally be seen more quickly and for more regular care. And if you have public insurance, however, this may pose some problems since a lot of dentists, unfortunately, don't contract with Medicaid. So patients end up paying out of pocket for a lot of the care that's delivered in the private sector. But this is a population that tends to have a fixed income, right? And unsurprisingly, also according to the Surgeon General's report, almost 29%, almost 30% of individuals with disabilities, actually, it's been found that they don't even obtain dental services, but because of costs specifically. So for patients who can't afford the private sector, dental schools and other training programs that are often affiliated with hospitals are the other main option, but not every state in the US has a dental school. Not every dental school has a specific program for this type of specialized care, and not every program is affiliated with a hospital. So as you can see, this is a very limited resource, and these programs almost universally experience very long wait lists. And since they're few and far between, with not every state having them, patients generally experience significant travel times just for sometimes a very basic dental visit. And so overall, what we have as this system, really a patchwork network, really, it fails our most vulnerable. And the separation of medicine and dentistry contributes to this because financing mechanisms are separated out. Dental services are not included in most healthcare contracts. And especially if you're someone who's living in alternative living or care arrangements, such as, if you're in a skilled nursing facility or an intermediate care facility, or you're receiving home healthcare services, et cetera, it's a challenge, right? So have Medicaid, good luck finding a provider. So fortunately, this is the experience of a lot of people. And these are some of the reasons providers don't like contracting with Medicaid. So low reimbursements, high administrative burden. These are very common things that a lot of providers cite as reasons they don't contract with Medicaid. And again, not all states have adult Medicaid dental benefits. And in a lot of states with more recent Medicaid expansions, there's been a huge influx of people without an influx of new providers. So that complicates things as well. But in California, things haven't been as bad, especially after Prop 56 tobacco tax money has been used to increase reimbursements for dentists and cover more services over the past number of years. Patients on Medicaid also tend to be sicker, just in general. And as I mentioned earlier, Medicaid, of course, also disproportionately covers people with disabilities. It's also within the right of a provider to limit the number of patients he or she has with public insurance. So a lot of providers who are listed as accepting Medicaid actually only accept maybe a handful of patients a year at that. But in effect, I would argue it amounts to legal discrimination, but that might be a bit of a controversial point. On the right is a breakdown of travel times experienced by patients here at UCLA's own special patient care clinic at the School of Dentistry. So you can see that around 2/3 of patients have travel times of over an hour just for a dental visit. And for folks with transportation difficulties or people who lived in institutionalized settings, this is a huge challenge, just logistically being able to get here. And if you do find a provider who takes Medicaid and who is also taking new patients, you might get referred anyway. One of the main reasons for this is insufficient training. The vast majority of dental school graduates, I would say, do not have enough experiences with treating patients with various special healthcare needs. Dental school education is still very procedure focused, so there just aren't enough experienced providers comfortable treating patients with special healthcare needs. A few other issues are also involved too. Providers are concerned about liability, especially as some patients are so sick. If anything were to go wrong in the dental chair, they're afraid of lawsuits, right? Also, of course, financial reasons, insufficient reimbursements, as we discussed earlier, are also often made worse. For example, a patient may need extra time to complete a procedure because of a disability. And since dentists are mostly paid per procedure, that takes up extra time in the chair, and that time is worth, therefore, less money, if you want to think of it that way. And these, again, are the reasons you might get referred. So if the current delivery system is failing this population, then how do you change the delivery system? So one way involves changing the way we educate the next generation of care providers. So in 2017, the National Council on Disability issued a white paper describing the inadequacies of the existing dental workforce and dental education, especially regarding treating those with disabilities. And this was huge. This triggered a chain reaction. It resulted in changes with CODA, and that's the Commission on Dental Accreditation. And in 2019, they now require that dental school graduates be competent in assessing and managing the treatment of patients with special healthcare needs. It's my personal opinion that it doesn't go far enough. They fell short of saying that they have to be competent in actually treating patients with special healthcare needs, but it only says assessing and managing, but it's a definite start, right? It's definitely a win. The white paper also called attention to the American Dental Association's own code of professional conduct. So in 2017, at the time of the writing of the white paper, it did not prohibit a practitioner from refusing to accept a patient based on disability status. But thankfully, this has been changed. And in late 2020, the code now prohibits disability as a grounds for a dentist's refusal to treat. So that's great. Another change happening is with specialty education. So in October of last year, 2 years, so 2021, I'm getting mixed up because of the new year, the American Dental Association House of Delegates actually passed resolutions number 46 to 48. And so the ball is rolling. It creates accreditation standards for advanced education programs in special patient care and geriatric dentistry. So this could really, really be a game changer. If special care dentistry and geriatric dentistry are formally recognized specialties of dentistry, this opens the door to a lot more. And so, yeah, so educational changes on the horizon. Increased postdoctoral training opportunities, improved education for dental students. So that looks like it's happening. Again, change is slow, but it's good. It's headed in the right direction. It also increases opportunities for federal funding and potentially even improved reimbursement. A lot of procedures, if they are performed by a specialist, actually, dentists get paid more for essentially being a specialist. We also need to be paying attention to the expansion of alternative provider models, as many states have already and are currently in the process of examining how alternative providers can help with workforce problems, and especially in combination with other innovations like teledentistry. So in like examples of these would be expanded function dental assistants, hygienists, and establishing a new mid-level provider called dental therapy, a dental therapist. And so changing the system of incentives is also going to be important, right? In 2020, the American Dental Association added new procedure codes for dental case management for patients with special healthcare needs. And this opened the door to payment actually being reimbursed for treating patients with special healthcare needs. The National Council on Disability released another white paper in last year. And this talked about how it's fiscally advantageous for states to expand Medicaid coverage to include dental services for adults with disabilities, that states would actually save money by focusing on basic services versus already paying for it in the form of emergency room visits. So, I think on a broader level, there's some movement there too. And same with accountable care organizations. So an accountable care organization, it's an integrated health delivery system. It contracts with groups of doctors, hospitals, other care providers. And when they're contracted, they're also held accountable for the total cost and the quality of care too for a defined patient population. And so you're seeing some movement on including dental services in ACO structures. And so last year, a very prominent dental service organization actually contracted with an ACO in the state of Arizona. So definitely looking forward to more movement on that front. And a good number of states have also recently expanded Medicaid programs to include adult dental services. So in the last couple of years or so, I can think of Maryland, New Hampshire, Hawaii, Virginia, and there's movement on that front. And when it comes to Medicare expansion, although it hasn't really been expanded yet, recently they did issue new guidelines about circumstances in which dental services are an integral part of an existing medical service that is covered. And just the cat's out of the bag when it comes to Medicare. Payers, general public are starting to realize that oral health care is essential. It affects other areas of healthcare and overall health. I don't think this issue is going away. When Congress was debating Biden's Build Back Better, it didn't pass, but that was one of the key items that people were talking about wanting to include in a revamped Medicare. So again, I think you'll see a lot more of this. I think it's potentially going to actually happen, and it's frankly it's far overdue. And value-based care and dentistry. So like medicine, generally a move away from fee-for-service toward alternative payment methodologies. And this focus on value-based care and dentistry, it's coming. And you're already starting to see it in several states, actually. And yeah, here we go. So, changes, alternative payment methodologies in California, for example, the state Medicaid program here, Medi-Cal, has a new initiative called CalAIM. And this experiments with pay performance within the overall framework of fee-for-service Medicaid. And this is notable because a lot of these incentives on the dental side are for adults. So additional payments for preventive services, continuity of care, including tobacco cessation services, minimally invasive care modalities like SDF, so that's silver diamine fluoride, And it's some of these are specific for adults with developmental disabilities or who are otherwise institutionalized. So there's a lot there, and they just started this last year. Additional support with teledentistry is also something you see across many states, and that really came to blossom during the pandemic. I'm not sure how well it's sticking around now that things are kind of back open, but you know, a lot of headway was made there. Emergency use authorizations, and these are all facilitated. All of these experiments, if you will, are all facilitated by federal waivers granted to the states, as the states are the laboratories for these innovations. So I think a lot of us are paying quite close attention to how these experiments, if you will, play out and lessons that are learned. And one more thing too, another element to pay attention to: state agencies for aging and disabilities. They look a little bit different, and they're called a little bit different, something a little bit different state by state, but they are also laboratories, and state oral health care funding can also be routed through them. So where is this all going? Altogether, these changes are really a paradigm shift in the way oral health is financed and delivered. You know, these changes are going to impact the way that dentists practice, as more incentives are moving toward minimally invasive and integrated care. I have a picture of one of the brands used for silver diamine fluoride, but it was already, you know, implemented in, like, I think the 70s, and now it's coming back. People are rediscovering, wait a second, maybe there's something here instead of just basic drilling and filling, and integrated care too. Let's see, you know, also using other healthcare providers in medicine and even community health workers to do prevention, you know, school-based health programs. You know, the burden of oral disease is immense. It's immense, and it's acutely felt by people. And, you know, it's increased emergency room visits. I think, you know, I think policymakers are really starting to think about this. And even within dentistry, you know, these innovations and these experiments are really playing out. And you see it also in shifts in the oral health grant making space. Foundations are really thinking about, just more broadly, how do you stretch your dollar? How do you support systemic change? And part of this is to move to more community-based care options. You see this not only in dental education with community-based clinical education models, but in fact, you know, the state of California, actually, the most recent budget included money to support community-based clinical education in all of its dental schools. So that's coming to fruition. And also in some of those 1915 waivers, I listed on the other slide, but also in special care dentistry itself. You know, mobile dentistry is really expanding, using non-dentist alternative providers, alternative within dentistry provider models, just to give a couple of examples. And of course, it kind of plays into this broader incorporation of looking at the social determinants of health and addressing them within the dental context. So shifting the distribution. So here at UCLA, our special patient care clinic at the School of Dentistry is kind of the provider of last resort. When private dentists don't feel comfortable seeing patients, they are often sent here. Same with other institutions that perhaps don't see patients above a certain level of medical complexity. And so unfortunately, right now, we currently see all levels of patient complexities. This is not an efficient way to deliver care. As a result, our wait list is very long. Just to get an initial appointment, to be screened, to see whether you can even be a patient here is almost a year long. And if you need OR care, it can take another up to 2 years before you actually have an OR date. So that's quite sobering. And frankly, it's terrible. There are no words for it. As changes come, we should be moving more toward a model that looks like, you know, the icon on the right, where tertiary care institutions like UCLA are really only seeing the most complex of the complex, and most patients can and are seen in community-based settings. I think the breakdown here, 85-15, is pretty generous. I personally think maybe upward of 90% should be able to be seen in more community-based settings, but this shift should be facilitated by the educational changes that we discussed. And it's not the end all be all of things, but along with other pushes, the push for teledentistry, alternative provider models, different places of practice, it's all part of the same trend. So hopefully we see see things a little bit more like what's to the right versus what we have currently. Yeah, and so how do we get there, right? And what should we do about it? I personally think it's all about making connections. Dentists as a whole are very siloed from the rest of healthcare, but also from each other, generally speaking. We tend to narrowly focus on things that directly affect us. Teeth are very small. Sometimes our point of view is also very small. But again, disabilities affect all of us. And so I say it's beyond time for us to really focus in on this issue. And we need to be part of the conversation. A lot of this is happening already, and dentists, again, also need to be at the table. And this is something we at UCLA's Special Patient Care Clinic are just starting to do too. It's very new to all of us. So thank you for inviting us to be part of the conversation. And this is why conversations like this are so important. We need to not only talk to each other, but open lines of communication with foundations, dental associations, legislatures, and of course, all the other stakeholders, including our own patients. Again, I think the grant making space is increasingly thinking about how care organizations better address the needs of our patients. And so, connecting with our own patients is super important. Adopting a QI framework and really engaging with our own patients and how to better meet their needs. And so things like patient and family advisory boards in dentistry, that hasn't really been done yet. So just to wrap up a few things about our efforts thus far, and when I say our, I mean our clinic at the UCLA School of Dentistry. Historically, the clinic and our director, Dr. Eric Sung, have focused on the clinical side of things, right? Really providing the highest level of care and expertise so that we can be the provider of last resort, and a very high quality one at that. I think over time, it's become frustrating that things sometimes only seem to get worse, right? The wait list isn't getting any shorter. We see other dentists referring us patients who could really be seen in their own practices without much additional training at all. And and these patients, of course, take on additional burdens to be on our wait list and travel, again, great distances for something as simple sometimes as a teeth cleaning. And so it became obvious over time that a broader focus on social determinants is really the way to improve. So since 2021, our special patient care clinic has had a licensed clinical social worker employed by us, who also supervises an MSW student. It's been great. Her name is Michael. She could probably give you multiple lectures on what she does because it's super fascinating. And dental settings are new to them too. It's not just new to dentistry. For us in dentistry, oftentimes it's like, wow, mind blown. But of course, this makes so much sense, right? It addresses a lot of the things, they address a lot of the things that we as dentists aren't trained in. Psychosocial support, care coordination, those aren't things that we really learn in dental school, unfortunately. So we're trying to expand the definition of the dental care team, to expand who's on our team. It's been wonderful. They've been able to help out with a lot of the issues that impact our clinic operations too. For example, they're helping us improve no-show rates, transportation issues that our patients come across, even with medication adherence. So it's, there's a lot more work to be done there, but it's something we're very excited about. We've also tried to increase our engagement with the policy world too, right? State budget and legislative processes, I mentioned, one focused on community care, community-based care. There's also another budget item also focused on building like an infrastructure grant for building new special patient care clinics. Engaging with the ADA on the resolutions, just talking to other folks, connecting with other programs, providers, and also connecting with our patients. We're currently trying to put together a patient and family advisory board for our own for our own clinic, because again, I think historically patient voice hasn't really been involved. So when you're thinking about the general shift toward patient-centered care, I think that's a critical element that we need to develop more. If anyone has any suggestions, please reach out to us. Even if it's to help with some of the discrete projects we're working on, teledentistry, a desensitization project, more focus on community-based care, reaching patients where they are instead of having them to travel this far just to get, basic care, and some of our research efforts as well as an educational institution, that's also very important. Everything again has been in its relative infancy, so I welcome folks to reach out to me, and I think the more discussion, the merrier. But other than that, that's all I have for today. So thank you for having me here.
All right. Thank you so much, Dr. Vitzthum, for wonderful scope on special care dentistry and just changes in education policy as well as care provision. I think I was very much struck by the current scope of where dental services are. And, we could go on and on about service provision and healthcare broadly. But I think, the biggest takeaway for me is just really understanding that most of us do experience oral disease throughout the course of our lifetime that are not just resolved, like as you had said in that metaphor, that it's not like a cold and goes away on its own without any form of healthcare. And truly that dentists are not historically integrated into medical care. It does feel like there is a silo and that it is a separate recommendation, at least on my end as a psychologist when I'm working with families, and it's just like tacked on as one of the recommendations. So I'm wondering for our families, as I encourage you all to include your questions into the Q&A, I think my biggest question for you, Dr. Vitzthum, is if there are any resources that you can recommend for preparing any of the individuals with intellectual and developmental disabilities as other care providers or parents, if there's anything that we can use as resources to prepare for any type of dental appointment.
Yeah, so this is definitely its own area, right? And so I think it kind of falls under the umbrella of desensitization efforts, right? To really prepare people to see a dentist, especially if you've been sitting on a wait list as an adult for many years. Maybe the last time you saw a dentist was when you were a child, and a lot of the progress that's been made maybe has been lost. And so this is actually something that I maybe briefly mentioned one of the projects, but we're trying to work on something right now. Long story short, right now, there isn't that much. There are some resources out there that exist for children, but for adults, it's a little bit difficult. I think a lot of the resources for children are in the form of picture books, but as for adults, oftentimes what we do is we have an initial screening day, and that initial screening day also has the dual purpose of not only just sort of getting all the paperwork done and seeing whether or not you're at the appropriate place, but also, kind of like a low stakes, just like to be in the dental environment again, right? To be able to sit in the chair, see the people that you would, be seeing in a later appointment. So I think in the private sector, that's something that I would encourage folks, parents and caregivers to really see if your local dentist is willing to just set aside some time for you. They don't even have to necessarily be there because obviously, there are financial pressures for dentists, but just to be able to sit in the dental chair, do a walkthrough of the clinic, meet the people that will be working with you during the actual appointment. I think, that's one place to start. But for what we're doing right now in terms of the desensitization project, it's actually going to be a set of videos that folks can watch at home within the comfort of their own home, and that focuses a lot on the sort of sensory issues that a lot of people encounter when at the dentist, right? Everything is loud, you have sharp instruments, there's a light in your face, we are in your mouth. It is very invasive. And again, you don't have to have any sort of disability to feel terrified, right? There's plenty in pop culture that has, derided, I guess, experiences at the dentist, but there's I think desensitization is something that, it's a conversation. It's a warranted conversation between you and whoever you choose as your provider. Again, unfortunately, not too many dentists are familiar with it, but it's something that can be suggested. And I'm sure that a lot of dentists would be very happy to oblige.
Great. Yes. And I think that that's a great opportunity for us to plug some of the desensitization projects that are going on at the UCLA Special Care Dentistry. So please, for our attendees, feel free to reach out to Dr. Vitzthum to contribute to that project and to get any of those resources when they're available. I think I'm just looking over at some of the themes in our Q&A just some other questions about resources or potential means to look up dentists who do feel comfortable working with individuals with intellectual developmental disabilities. Any recommendations there, Dr. Vitzthum, in how families can navigate finding a provider?
Yeah, I would say, especially if you're already connected with a regional centers, I think most of them in California at least have a dental coordinator, and they tend to maintain lists of dental providers that are willing and able to see folks with disabilities. And so I think that's a great place to start for a lot of patients. But unfortunately, sometimes it's just a conversation, right? I think a lot of dentists are potentially willing to see patients with special healthcare needs. They're just a little bit afraid, right? And so they don't know what they don't know. And having that initial conversation with them, at least explaining, and also if you are coming in with a lot of medical complexities too, making sure you have all of those records with you, making it as easy as possible for the doctor to make the assessment of, well, is this appropriate for me to see you here? I think that helps, but I would very much encourage folks to at least speak with their regional center, because they do have a compilation of their own resources of who's in the community that is open to this population.
Great. Okay, so start with the regional center. I mean, there are always a host of resources for any kind of question, but I do think that that's a good takeaway for our audience. I think another theme that I'm seeing in the Q&A box is really related specifically to UCLA Special Care Dentistry. And so one question is if the special care dentistry, if you accept Medi-Cal insurance, is that something you accepted there? Okay.
Yeah,
wonderful.
And so the vast majority of our patients do have Medi-Cal as their insurance. So that's, unfortunately, that's also a number of, that's also why folks come to us. And sometimes it's financial too. They can't find a provider that offers that level of care that is willing to take their insurance.
Okay, great. And how do families connect with the special patient care clinic?
I would visit our website. There's a phone number you can call. Unfortunately, as I mentioned before, our wait list is quite long, and it might be a while before you can get an appointment. But at least having a conversation with them about whether or not this is an appropriate place for you to gain care, to obtain care, I mean. But again, I would very much encourage, reaching out to more community-based resources. It's difficult to come to UCLA. It's obviously we have the care, but it might not be very fast. But if you do have to be seen in the operating room or under sedation, these are services that we have here at UCLA. And unfortunately, not many private practitioners offer those services. There are a handful, I totally understand the difficulty a lot of families are going through when trying to seek care for their loved ones.
Absolutely, right. Just wanting to have some information on what they can do. Another question that I have is in terms of all of our service providers or care coordinators that are in the audience, what recommendations you have for us for preparing any of our patients or families for referrals to special patient care. I think the big desensitization conversation is probably paramount, but any other suggestions that you have for us in preparing our patients for dental care?
Again, I think open communication is the best. Sometimes even when coming to our clinic, sometimes things get delayed because, it's communication on our end and it's coordination. I think, more than anything, it's kind of going into it with an understanding that it's a logistical feat. We aren't connected very well. And I'm not talking about us, but generally speaking, dentists aren't very much connected to the medical world. So if you have, a long list of diagnoses, for example, a long list of medications, it might take some time for your dentist to really examine your case and to talk to all the folks that they need to talk to in order to make sure that, dental care can be delivered safely and appropriately. I think if anything, it's amnesty because most dentists aren't really trained in this unless they specifically did an additional training program in hospital dentistry and special care dentistry. So, again, kind of arming yourself with all the paperwork and all of that, and really understanding that the process might take a while because we're not as easily connected to the rest of the healthcare system, I think is a good sort of baseline perspective to have.
Yeah, I know, right? Just being that squeaky wheel, and I always encourage parents to think of themselves as kind of the quarterback or the CEO for care coordination, and having all that information to advocate for their needs.
Insurance and all of that, it's starting to change to better cover folks with disabilities, but insurance is not set up for this type of care, right? Reimbursement codes again are coming down the pipeline. But one of the complaints that we've heard as well is, and something that we've experienced too, is dentists can try to submit these new codes because they've never done it before, but rejection after rejection comes. And so it's difficult for providers to even get paid to do this, which is why, with the administrative burden, it's understandable that a lot of folks, a lot of providers elect not to cover or not to take public insurance. So it's unfortunate, but it's a complex interplay of a lot of different factors, and together there are significant barriers. So having patience is really important with us, even if this is all we do. We still encounter a lot of barriers.
Right, that's true. Right, in terms of healthcare, our systems are working as they were intended to, which unfortunately does not actually provide good care and serve the patients that we need to, unfortunately. Yeah, I'm noticing time. And so I want to thank you, Dr. Vitzthum, for this excellent talk in introducing us into the world of special patient care and dentistry. For our audience, the slides and the recording of Dr. Vitzthum's talk will be available on the UCLA Tarjan Center website in just a couple weeks. So please keep an eye out for those resources. For the special patient care, I believe the website was included in the slides, as well as Dr. Vitzthum's email address. You can contact her directly. I encourage all of our attendees to take this information and to use it to become advocates, to really push for more dental care services for all of our families and individuals with intellectual and developmental disabilities. It's really unfortunate to, and to be introduced to the scope of the problem and to want to do more. But I think that we have such a champion in expanding dental services with Dr. Vitzthum and what they're doing at the UCLA Special Patient Care Clinic. And so happy to be a part of that and to advocate for us to continue to partner and move the needle for those that we intend to serve. All right, and so I hope everyone enjoys the rest of their day and they're having a great start to 2023. We're looking forward to seeing you at next month's lecture for our February 2023 Distinguished Lecture Series, and then we will see everyone then. Thank you, everyone.